I'm Holly Khan. I'm Principal Podiatrist at Central Podiatry. I'll be talking about myofascial pain syndrome and trigger point therapy and my clinical experience with treatment with the shockwave therapy machine. All right, so you're in your clinic and you have one of those patients sitting in front of you. I've got pain here, I've got pain, it tracks down here, and it's a pulling pain here, and sometimes it's on the right side, and sometimes it's down on the left side. It's only when I'm running. It's on the bike as well. I've had an MRI done, I've seen specialists, and I just don't know what's going on. Don't you just love when they're sitting in front of you? You sort of just get a little bit overwhelmed with everything that's going on. But you just have to remember, break it down. Hopefully, everything will be all right. Myofascial pain syndrome. It is a muscle pain condition. It's classified as a musculoskeletal disorder. As clinicians, we are always striving to be able to provide the best treatment in the most effective way, with the best outcome and in the least amount of time. Definitely the Swiss Dolorclast I have found, and it has been proven to be very effective in treating such musculoskeletal disorders. Characteristically, a myofascial trigger point, taut, hard band, found within the muscle or fascial tissue. They can cause pain. They're painful when they're pressed on. They can cause a tightening by a shortening of the sarcomeres in the muscle fibres. Therefore, they'll definitely reduce the normal muscle function. They can also, as we know, cause referred pain. So it's something we've always got to try and remember when we've got patients presenting in front of us with, certain painful conditions. Sure enough, it could be that, plantar fasciosis could be actually that condition, or it could be also a referred condition as well from a myofascial trigger point. Factors commonly cited as predisposing to trigger point formation. You've either got the acute or the microtrauma. So such things as acute trauma, car accident, sporting injury, fall, something suddenly tearing a tissue causing that muscle trauma, or you've got all of the microtrauma. So everything from repetitive mechanical stress to lack of sleep, vitamin, mineral deficiency, joint disorders, constant clenching and tensing in the muscles from mental or emotional stress, and all of the habitually bad posture, so sitting at desks for a prolonged period of time with the hunchback and all the tension up on the muscles in the shoulder. Definitely does not do any of our muscles any favours. Trigger points. We need, a bit of a laugh with it's very reflective of us sitting in our clinic when we've got our patient in front of us, and we tell them what their diagnosis is and what their management plan might be. Expensive orthotics and expensive footwear, shockwave therapy, and sometimes they're not always happy to hear the diagnosis with the very expensive, possibly expensive management plan. So trigger points. So they can present secondarily to other pathologies. Trigger points may actually be causing that painful symptom attributed to that condition. Such diagnoses may include back pain, knee pain, heel pain, elbow pain, all that type of stuff, sciatic pain. So definitely always be aware of these nasty little things, because you just can't forget the point that muscles have often been a very underdiagnosed, a very under-recognised cause of pain. Our muscles are so important. We can't have nice, strong, healthy, well-functioning muscles if they have got the nasty little trigger points causing the lack of function. So, how do we treat these? People often can try some self-treatment, see a GP, or even see one of us for treatment of these. And if we're not picking up on them, the people at home, they can do self-remedies such as taking anti-inflammatory, muscle relaxants, antidepressants, even strengthening programs. Because if you've got a problem with a muscle, well, often it is too tight or not strong enough. But often these therapies may prove to be ineffective, cause some pain relief, in some cases, or detrimental, such as a strengthening program can actually cause more strain, more tension, and therefore more pain within a muscle tissue. So with trigger points, we know that there's the active and the latent phases of the trigger points. Within the active phase, we've got they're painful, can cause debilitating pain, muscle weakness due to the taut bands, limited flexibility. Then they've also got all of the referral symptoms that can go along with it. Those symptoms, a dull ache, they can be burning, pressing kind of pain, aching pain, a large range of pains that can be associated with them, even numbness and fatigue. Latent, so generally they're not going to be painful unless you push on them and find them. They can be hiding deep within a muscle. They can be present for many years, even after apparent recovery from injuries. You know, that person who had the motor vehicle accident 3 years ago and all that muscle tear that could have happened. That's why it's so important to take into consideration your history taking, what previous injuries have you had. So restricted movement, disordered muscle movement, patterns due to stiff and weakness of the affected muscles. These things as such will cause the stress and fatigue. So stress and fatigue is what will possibly cause a latent trigger point to then go into being an active trigger point again. Pain everywhere. This can be a symptom that we do have presented in the clinic. Someone can think of like fibromyalgia, which is a sort of a separate condition to the myofascial trigger points, myofascial pain syndromes. Prolonged referral of pain and weakness from one trigger point can actually, it can cause from one trigger point to a referred area of the body will generally cause other trigger points to occur in that part of the body. These in turn, if they are left untreated, can be activated and also cause refer pain, creating multiple pain patterns. So obviously you can have trigger points in sort of all the muscles throughout the whole body. Most people will have a few trigger points in their body. They might be latent, but yeah, you can have a lot of them. Treating each trigger point may be simple, but treating the symptoms of the whole myofascial pain syndrome to ensure that the pain fully goes away is key and can be a bit difficult. So the Dolorclast, as I said, I've had it for about only 6 months now. Prior to the Dolorclast, if I'm, seeing a patient in clinic, it'd just be a lot of soft tissue massage. I didn't do any dry needling. I was interested in doing that course, but I had a Graston tool. I had just the, hard pressing on the trigger points themselves. A lot of physical work involved in that, and also time spent on trying to provide massages with the elbow and whatnot. So as we've also discussed previous presentations, marking the area is definitely key, because you want to find out, well, firstly, where is that patient having the pain? Is that pain in one area, 2 areas, 3 areas? You want to find out if it's specifically referred or localized, what's the pattern. Then the other key point in marking is then once you've got the trigger points on those spots, it's going to sort of numb the area, so you want to make sure that you can stay on that spot for the amount of time that you want to. So I would be doing that for around the 500 shocks per trigger point, and knowing that you can sort of, you might do around 8,000 shocks per treatment, you can sort of divide it up dependent upon how many places that they need treated. So you want to choose the gun. If you've got a selection, I use the power gun and the Evo gun, and then within those 2 guns you've got different heads that you can use. Occasionally we use the one head for every site within that whole person. For example, I might use the large head for the full ITB in the ITB fascia area with the large head, or I might use the Evo gun that's also got a trigger point head, for example, for around the glute med trigger point areas. Once the trigger points have been released, the muscle should also, you should move the muscle through the full range of motion just to give it a real stretch out and lengthen the muscle fibres. You want to always consider conservative therapies. So dependent upon what that person is presenting to me for, I've had previously I've had a patient who's presented with a shoulder injury, tendinopathy. He went through corticosteroid and physios and everything. Not that this is myofascial, but no, I wasn't going to be providing any shoulder conservative therapies because, you know, obviously we don't, as a podiatrist, I don't know too much about those areas, so he can see a physio or someone else for that if needed. But in his case, he had 3 treatments and he was completely healed of pain. He does manual labouring work. He's had the problem for, I think, about 10 years or so, so that was just like an amazing success for him. So, as I was saying, conservative therapies, so strapping, footwear, orthoses, stretching, supplements, drinking water, definitely agree that's very important, and also stress relievers because of the stress association with myofascial pain. Generally, I would do around 3 visits and space them around 1 week apart. And you do definitely find most people will experience pain reduction within that first visit. So it seems like a lot of you are already using the shockwave therapy machine. It's just amazing with once you have, say, a shoulder trigger points, patients are just immediately putting their arms up in the air and just have that immediate increase of range of motion. Soleal stretching test, just to do the soleal stretch test, sometimes I've had 2 centimetres increase in range of motion simply from releasing some of the lateral head gastroc trigger points and just going up and down the whole gastroc soleal complex. So that's pretty amazing to have such an instant improvement in function of the muscle. Okay, so I've got heaps of case studies. The triathlete who I was talking about in the very beginning with pain everywhere, well, she's a triathlete, 3 years duration of right leg tightness, pulling tight pain, grabbing sensation, feeling like it needs to be released, is how she was explaining it. She would always get it during efforts on the bike, and then with time it sort of developed during her running as well. Particularly around the proximal hamstring attachment point, right quads, specifically intense around the medial and distal aspects of the quads. Tightness can also occur mildly in the lower legs, lateral compartment, mainly on the right side, but just to add it in there, a bit on the left as well. So history pattern, no previous injury. Initial onset was during an Ironman in 2010, I think that one was. 2012. Symptoms continued to slowly worsen over time. That was particularly only during her training sessions, uphill bike riding, things like that. And pain would subside with cessation of activity. Now, previous treatment did include massage and physio, stretching, strengthening programs. She did rest for a while from training to see if that would help. Sports specialist, needling, all of that. A Ironman 1 year later did not work out too well for her due to all of the pain. She'd seen a specialist, an MRI, nothing was showing up. It just indicated wear and tear, stress reaction on the lower spine. Location was, as I said, already went through that, great. Proximal hamstring attachment site, glute med, around the sartorius, because it'll sort of cross over here, lateral lower leg, down the perineals. In assessment, moderate tightness of the ITB, gastrocs and soleals and hip flexor muscles. Had good strength of all the hip and core and lower extremity muscles, very good. Fairly neutral foot posture, gastroc equinus, in gait this is gastroc equinus, and she had the abductory twist. Provisional diagnosis. It wasn't my only one, but we're going with it. Myofascial pain syndrome was sort of coming to mind with all of these referred pain patterns. There was direct pain on palpation in some areas, and then also referral pain pattern happening as well. Differential diagnosis with the symptoms reported chronic exertional compartment syndrome of the quads of the right leg and also of the lateral compartments of the lower leg bilaterally. So we did a treatment with the shockwave therapy. We did 3 visits spaced 1 week apart. I used the red power gun. I'm fairly aggressive with it, so I'll always introduce it to the patient really easy on 1 dot. Can you feel that? Yep. Gradually increase it until they can handle maximal. So they're pretty much, a lot of my patients are cringing on the bed, and then obviously when you move it around you can get to those more intense spots, which is where I'm going to focus on specifically. So with her we did all those areas that were reported painful, focusing on any particular trigger points that were found. After 1 week she had a significant pain reduction. She was able to kick, so during swim squad, kicking only, she used to almost get out of the pool and vomit in pain. That's just how bad a condition that she was in. But after one week of freeing it all up, we probably did around 9,000 shocks or something in total. She was able to do a faster kick in the pool without all of that excessive discomfort. 2 weeks later, 1 week later, we redid the same method. And then on the 3rd visit, being a 2-week outcome, she had once again further reduction in pain and also improvement in function. She was able to feel on the bike that there was a little bit of less pain, but it's only short term, and it was just great to be able to see within the 3 weeks she had such a great improvement. So once again, shockwave therapy was done for her on that 3rd day. 12-week outcome for her. She had no pain. She actually forgot about any pain that she had up around the proximal hamstring attachment site. Like I said, there was an MRI done, so we weren't going to say that it was insertional hamstring tendinopathy, because that's obviously one of the other differential diagnoses that would have been there. But she wasn't having any discomfort at all on the bike at the hamstring site. However, she still was continuing with a bit of pulling tension pain around the quads. So, and also with efforts during running. She could be running at, say, 4:30 pace for an hour, but tell her to run at 4-minute pace and up the ante, and she was just struggling, and she'd just have to pull the efforts back. And you'd see her at the training, she'd be on the foam roller, rolling back and forth just to try and get rid of this pain. So I referred her back to that specialist, particularly to get compartment pressure testing for the quad. She was supposed to have that testing done a week ago, but he had to change it, so that would have been nice to see. Stretching of the hip flexors, ITB, gastrocoelial was given, magnesium oil application, and foam roller. Just trying to keep those other conservative therapies in play, and she's just going to wait to see if she gets surgical release of the quads if that comes back positive. It's not something I would generally see, quad compartment syndrome, but it sort of seems to be tying in quite nicely with all of her symptoms. It was a very interesting one. Another triathlete, Rod, calling the problematic calf muscle guy, his complaint was just pain and stiffness in the bilateral calf muscles during running. The onset of pain would be around the 1 kilometre mark. He had it for 2 months in the right side and for around about the 5-month mark in the left side. Previous injuries do include a left side Achilles tendinopathy, which had been 2 years prior, and that was during playing soccer. Soleal measurement was around 9 centimetres on the left and 12 centimetres on the right, so a bit restricted, particularly for running. Previous treatments, he'd stopped running for a while, physiotherapy, stretching, strengthening exercises, the normal type of things that you would do for sore calf muscles, tight calf muscles. Our podiatry treatment included nice massage first, just to sort of kind of detect where the areas were. Really large really large hard mass, smack them in the medial lower gastroc head. So, where am I up to? That was it, both sides, but definitely left more than right. So the shockwave therapy was done again. Red power gun was used, 3 power bar, large head. So we sort of focused on, there was particularly 2 different myofascial trigger points that were located inferior to the medial side of the gastroc head. And around, we also did lower in the soleal area and around the Achilles tendon, because there was also just pain on palpation in those areas there. So he was also advised on stretching, ankle joint range of motion exercises, footwear was examined and appropriate. On that second visit, same thing again, shockwave therapy. Soleal stretch, we measured a bit of an increase in the stretch test after the shockwave therapy on that second visit. On the third, we weren't getting a pain scale then because he wasn't getting any pain just with his general activities. He was told to stop running just for those few weeks. So we did the third visit, same method. Then he was very keen to obviously get back into running and soccer playing. So we did implement him on a slow run build. And yeah, at a 5-week review, his outcome was absolutely no pain with running. Remembering he was having pain with the 1 kilometre mark, so he was already starting to run. He was up to around about 4 kilometres within five weeks. So he sort of just increased it around 1K each week, and he had, and that initially, that was only a warm-up run, so very slow run. So he was pretty instant, great outcomes. I can liken him to another patient who had very similar symptoms, and I was doing deep tissue massage for him and very similar treatment to him. He was also, his father-in-law was also giving him deep tissue massages as well, and his outcome was nowhere near as successful as Rod's. We also did a bit of mobilisation of the ankle joint to try and free it up more, and it went from the left side particularly around 9 centimetres to up to around 11 centimetres. So obviously that's going to help to prevent the continual overload of stress with a restricted ankle joint during running. Vaughan, he was a very interesting case. He came in chronic debilitating pain. It was just totally stopping him from being able to enjoy his life. He was around, probably around 55 years of age. Chronic left foot and left hamstring pain, left shoulder pain, constant pain, and just ruining everything really. He had to pretty much retire from, he couldn't work. 10 out of 10. When it was at its worst, things like standing and walking would worsen the pain. He had had a spinal fusion 20 years ago. He had had previous massages, which would reduce pain in the short term. In gait, just a bit of moderate overpronation, antalgic gait, nothing too, nothing too remarkable with the brief biomechanical assessments that I do in the shockwave therapy appointments. Treatment. Red power gun. I like the red power gun, particularly for the bigger guys. They can.
You guys know, we don't know what the power gun is versus that one. It's just to explain.
Yeah, thanks.
Yeah, this one's about 2.5 centimeters deep, and this one 4 to 4.5 centimeters deep. So where you need that, and obviously just a bit deeper. That's where that's.
And a lot stronger, more painful.
Yeah,
So.
It does have a bit more punch too. Yes.
Yeah. All right, so for him, we used the 3 power bar, small head for the foot, then we whacked on the larger gun for the hamstring, and also to get the trigger points up in the shoulder region. Locations, left side insertion, a band of plantar fascia. I always go up the plantar fascial band and also hold it on the insertion of the plantar fascia for at least 2,000 shocks. Left hamstring, around about 3,000 shocks or so, specifically along the biceps femoris muscle belly for him. And then also 2 different trigger points in the shoulder, trapezius and latissimus dorsi regions. Second visit, already reduced down to 5 out of 10 pain. He reported, "You're a miracle worker, feel like I have a new hamstring, It's out of this world difference. I have had all this pain for 30 years. I've tried everyone, tried everything, even cut down my painkillers. So it's really satisfying. Everyone knows how it is when you get a patient coming in and you want to do everything you can for them and they come back and they're having great success. So that's what you love seeing. Once again, shockwave therapy was done. I think I did on the second one a bit as well on the calf because we were freeing up the hamstring and then he was actually feeling a bit of tightness in the calf muscle as well. So you always got to remember if you're freeing up one area, it can cause a bit of overload of pain, or not pain, stress, tightness on another area as well. Second week, so this was a third visit, feet 100%, hamstring was unreal, 2 to 3 out of 10 pain was at its worst on the pain scale. He was able to work in his brother's butcher shop. So he hasn't been able to do that, and whenever he had to do that, it was just like a death sentence for him to be standing on the hard floors. People would come in, people would just see him visibly in pain. So now he was just so excited. He was able to walk home from work. Other people would come in that know him because he's just a local guy, and they're just like, what's happened to you? You just look so good. You know, actually enjoying yourself. Anyone want to ask any questions?
Yeah, so how do you get to places like, the sciatic area?
Yes.
It's a bit hard sometimes, isn't it?
Okay, yeah.
Sorry.
No, that's a good point.
You're going through all these areas that you're talking about.
Yeah, so sciatica, definitely advised, that my third point here, advised to consider chiropractor for assessment of spinal or pelvic issues. It's definitely out of my league to go up and investigate around the spinal area, so I'm not even going to try that. Oh, you got cards here. Yeah, thank you. So with this one, it wasn't. I'll go through it. It's another interesting one. I hope you guys are you guys going all right? Yeah. Sciatica. So Jessica presented 8 out of 10 sharp right plantar fascial heel pain, numbness down the posterior right hamstring, and also reported lower back pain. Gradual onset, no injury history, or no change in activities. Walking worsened the heel pain, sitting worsened the numbness in the posterior upper leg. There was pain on palpation at the insertion of the plantar fascia and on the trigger points in the lower back. In gait, there was a left higher than right shoulder, early heel lift, prolonged pronation, antalgic gait. She was leaning to the left side. Neutral foot posture, in the static stance position, Trendelenburg's within normal limits, everything else looked fairly good. Hamstring on stretching, 45 degrees, and she was just like already, okay, don't stretch the leg anymore. Left side was within normal limits. Slump test was a positive result on the right side, indicating the sciatic irritation. So pre-visual diagnosis, there was a lot going on there, and some of these patients, they're booking in for an initial shockwave therapy appointment. And so we're doing what we can for our biomechanical. Some patients we have to just rebook them to come back in for a full biomechanical. So provisional diagnosis, sciatica causing numbness down the right side, right hamstring, possibly due to compression from the compensatory gait, due to the right insertional plantar fasciitis, plantar fasciosis. Should have that there, I do know that. Lower back trigger points causing pain and tightness around the quadratus lumbarum and ilicostalis lumbarum trigger points. Because, I don't know, I think I skipped over that. Duration, her heel pain, this is acute, so her heel pain was only present for 3 weeks. And numbness was only present for 5 days. So it's a very new problem that she was presenting with at the clinic. So our management plan, like I said, chiropractor, please. She didn't actually go, we'll find out in a moment, she didn't go and see the chiropractor. Sciatic nerve, bit of flossing, the Lodi strapping, supportive footwear. Okay, so you mobilise it, you're moving the nerve through the tissue, mobilising it basically to reduce the irritation on it. The shockwave therapy was done on the right side. We did trigger points, Evo gun was used, trigger point had 500 shocks around on each trigger point. The trigger point head's really long, narrow and skinny. Here it is.
So you're literally working on trigger points here with the gun?
With
So-
all trigger points around the
this is where I
glute
come
med?
back to.
Yeah.
You have to remove clothing.
Yes,
to
I
get to
do.
that point,
So we
right?
have towels.
So how do you manage this? This is more the point was.
Oh,
getting to.
manage. Oh, okay, no, they.
No, because if you ask
I'll-
someone to, strip off.
Yes, I do. I'll say, here's it. I'll put a towel on the plinth, and leave a towel on top.
Okay, like massage
Tell them
type
to,
situation.
yes,
Yeah.
exactly.
Okay.
I've had people who have stripped right down. I've just leave it to them because I'm going to work around the piriformis,
Yeah.
around the glute. Some people have worn running shorts and I haven't they're
No,
so
you can just-
light and flexible I can
Yeah.
lift them up. So it is a nice point to ask people if, wear some tiny little running shorts and you might not have to get them to take their clothes off. Otherwise, just pop the towel over the top of them. Yep, that's it. I know it's a bit different because
different from the face.
it is exactly. It was starting to get in an area that I hadn't sort of been working with. It has been my insurance. I know that my insurance covers me to be able to use the shockwave therapy on all areas of the body, and that's where it comes down to with me. No, sorry, podiatry insurance covers me to be able to use the shockwave therapy on all areas of the body. Yeah. So I looked into that, and yeah, that's fine. So trigger points, if you're well aware of, the trigger points themselves and how they can, what you're treating. Like I said, I don't like to go into other areas. Referral onto physio, chiropractor, anyone else that would be more experienced in other areas if they need to have other conservative therapies played in with that. All right, so you've got our method there, hamstring. Oh, so we specifically went down around the sciatic nerve course, went around the plantar fascia, and when she came back on the second visit, no heel pain, but just a mild numbness. There was a bit of tightness now in the right calf. We didn't touch the right calf on the first visit, and there was no symptoms of the right calf in the first visit. Shockwave therapy was done again. We actually did the calf muscle this time, and there were some trigger points around the soleus and the medial that can be referral of the numbness down into the heel, or that can be coming from the sciatica, obviously. And we also did the hamstring and the piriformis. So on the third visit, outcome, absolute complete resolution of the heel pain. Now remember, this was an acute injury, acute presentation, only been present for 5 weeks. She was stoked. She was really happy. She was actually happy that she was just able to sit comfortably. Previously, she was getting the shooting pain, discomfort around the bum, limping due to the tight calf muscles. She felt like she was walking like an old woman, compensating gait, overloading the left side, but now nothing. Now walking straight and normally can do. She was really happy she could just do her own shoelaces up, so that was really nice. And there was the hamstring range of motion went up to 90 degrees from that 45 degrees. So I treat myself all the time. My husband Raya, treat him as well. Trigger points,
You take
glute.
better than Ryan.
What's that? I take it, yes. Oh yeah, no, it's hard. Isn't it nice to treat yourself? You're just like, no, pull it off, too high. No, but I do like to go nice, as high as you can. So you're always getting that patient feedback. How high? You make sure that you tell your patient and don't get distracted when you're talking to them. Okay, constantly give me feedback. We're going to start off on 1.5, we're going to go up to 2 when you can handle it, and then, move it up to even 3. I just find the higher you go, the more effect you're going to get. One of my clients, Achilles tendinopathy, it was on our trial day that Roland was there. Okay, so she was desperate. She'd already had 2 lots of corticosteroid injections. She then came to see me. Over 10 weeks of treatment, we did everything we could for her. Deep frictional massage therapy of the Achilles tendon and up into the calf muscles themselves, ankle mobilization, orthotics, strapping, footwear, obviously the eccentrically focused heel drops, heel wedges, everything. and she got a little bit of reduction. She got reduction in pain, but this is the reason why she is one of the few patients that I got the shockwave therapy machine for, because you want that faster outcome. I don't want patients to have to come back over and over and over again for a longer period of time. I want a faster result for them. And she was just stubborn. Her Achilles tendon was just stubborn. It wasn't going anywhere. So I'd already done all the conservative therapies that I'd done that I would usually do for Achilles tendinopathy. Obviously, you do have people that will respond to it and have complete resolution, but you'll have those other people that don't. She was not an easy person to do the shockwave therapy on. We literally had to use the standard gun on the large head. We started off on the first visit with the small head. Oh no, not the large head. There's only the small head.
Yeah, 15 mil.
15 mil?
The one that's on there now.
The fifth, yes. Standard head, standard tip. 1 dot for the first week, maybe 2 dots the second week, 2 dots the third week. I didn't realise I wasn't too aware that, you know, you generally only do 4 to 5. Like I said, nearly every patient of mine's 3 visits and that's it. Anyway, with her, we had to do around 7 visits, and she was, because it was such low levels, like she could not handle any higher. So anyway, outcome with her, we had a 12-week review, and this is 3-year history of just chronically debilitating Achilles tendinopathy, mid-portion and bilateral, mind you. And yeah, so outcome was shockwave therapy. It was the only thing that finally got her back to no pain, but when she had a 12-week review on squeezing the mid-portion, there was still pain and inflammation there. I highly recommended her to have another 3 courses, and hopefully we would have been able to go up to a higher level to get a greater outcome. She was a bit hesitant because she wasn't wanting to, she didn't like to have the treatment done as much as she loved the outcome. She's like, let's just wait and see. So we're doing rock tape strapping and things like that. And she's still wearing, you know, the orthopedic shoes even, and orthoses and things like that. She'd just have the abductory twist and the stress overload on that Achilles tendon. So just quickly, other things that you can notice with the release of the trigger points are just that muscular shift and as the muscle returns to the normal function and normal loading. You will notice patients will sometimes have the pain associated with it during and even a little bit afterwards. And sometimes, yeah, you do need to make sure that you free up other areas well if they're going to be starting to function more. And then me, I treat myself all the time. One interesting thing was I'd done an intense running session, and I'd eccentrically loaded my calf muscles walking backwards down the hill on hill reps. So I'm like limping in pain with my calf muscles just like screaming out at me. I've got competition in a few days' time. So the pain had only been there for 2 days, so I get the shockwave therapy on me. I only did one side because my husband was in the car waiting for me to go. He was going to drive off without me. So I only got to do my left, I think, yeah, it was probably around the cilial area. Put it on there. I only did 3,000 shocks, just sort of doing that ironing momentum because I do that as well. Anyway, immediately there was a significant pain reduction on that left side. There wasn't that constant rip pulling pain that I had on the right side, which continually occurred for the next few days. But yeah, there is, you can definitely feel, obviously that is a, that reduction in pain, but it's also just causing all that tissue regeneration that you want to see in treatment of patients. All right. Thanks for listening to me. Thank you very much for listening. I hope you enjoyed it and picked up a few handy hints. For any more information, please have a look at my website, centralpodiatry.com.au, or please feel free to email me. Have a look at the credits to follow for that information.